I'm not sure that I could really say that I've ever really known what I wanted to do in medicine. My idea of medicine changed over the years. When I went into medical school, it was kind of a Norman Rockwell picture that I had. And when I actually returned to my hometown for a month, which was required in my medical school, and practiced with my Norman Rockwell type country doctor, it was that experience, which is very nice, but very different than, let's say, when I finished internal medicine residency, and that training was resuscitating really sick people in the hospital for 3 years, working and training under specialists. So you were kind of a you were not a specialist, I suppose, but you had trained under all these specialists, so you knew quite a bit about cardiology, gastroenterology, hematology. You ran the intensive care unit. You ran the coronary care unit. So you were good at really sick stuff, complicated things. And I liked that, and my mind needed some stimulation, so that was good. So I thought that's what medicine was. Then when I left residency and started in private practice, well, I wouldn't have done that if someone would have hired me, but it was 1988. It was Loudoun County. I was the only woman in the internal medicine department. It looked funny to see women in there. I remember the time when I had a really sick patient in the intensive care unit and a 2-month-old baby, and at 2 in the morning I have the baby in the little rocker thing while I'm at the bedside with the patient, and so you do what you have to do, and people were saying, "What? You're bringing the baby?" It was like, I don't have any child care. My patient's sick, and my husband's out of town, and here I am. So that was different, I guess. So then there was that piece of my life, still kind of incorporating the residency program with now outpatient medicine. Well, people don't knock on your door saying, "I need, to be intubated," or "I'm having a cardiac arrest." I mean, you see people who are sad because they're lonely, or someone they love has just died, or they're going through a divorce, or they have multiple chronic illnesses. So then you start managing that, and you get involved in the social aspects. So can they afford their medicines? Is it an elderly person being abused? So it's not just resuscitating someone or making a great diagnosis. Now I don't go to the hospital at all, so I don't. All that stuff that I learned, I can't say it's a waste, but I don't practice it anymore. So we have hospitalists, we have outpatient doctors. So my life is totally outpatient. But I really changed, I have to say, in my view of medicine when I was a patient. And so I spent a year in bed, and it was complications from trying to get pregnant from IVF. And it's interesting, but about 15% of American couples have infertility. So this is a common problem, not really talked about very much. And I just assumed I could go to these specialists and get good care. And I got horrible care, and I was treated horribly. Women are shuffled around like cattle getting these procedures done. A tremendous amount of money, and a tremendous amount of heartbreak when it doesn't work out.
I was going to say, I think complicated with that is the heartbreak. And I think when women are having children at a later age, I think that those opportunities, if we're not younger, which is kind of like this curse, because we're now told we can have it all. We end up putting our education first, we put time into our careers, and then we wait. And then we go to try to have babies, and it's just not happening. And then we end up going and reaching out, and I think that is true. I think it's heartbreak, I think it's pain, I think it's fear, I think it's health care, I think, I think it's shifting. I think there's a lot more compassion, because I think women are driving that demand that I have more compassion and better care. But I think in those days, it was not as much that way.
I think we've lost our minds in medicine, quite frankly. This profession has morphed into something that it just shouldn't be. But anyway, back to that situation. So I hate television, and I would watch paint dry before I would turn it on. So I'm laying in bed, and it's, I didn't know I had a year ahead of me, but anyway, as time went on, months went by, and I had all these problems. And my mind was still active, and I needed to not go crazy. So I was running my business from my bed, and I would have meetings, and the only rule we had was you can't get under the sheets. You can actually sit on my bed. This is where it stops. But we had a lot of laughs about it. But anyway,
So at this point, you were in your own practice. You had your own.
Oh yes, this was. Let me see. My bed confinement was like 12 years ago. So I started the practice in '88. So yeah. So I had a large business at this point, and I was just plucked out of it. the show must go on. So I took a distance learning course from Harvard on complementary medicine. And not because I had any great insight. It really wasn't a vision that I had or anything like that. I just took it because I was bored. And patients had come in and said, is there an herb for this? I don't want to take these drugs. And then being an internal medicine specialist, I was saying, well, of course, the drug is the way to go. I'd been trained to do that. So I was very indoctrinated into thinking that I had a drug for everything. And I did. I had a drug for everything. But then as we were practicing medicine for years, I was realizing that people are having problems with these drugs. And I'll never forget a patient that almost died on me, and me being at their bedside in the intensive care unit because I had prescribed a drug that caused a perforation in their stomach. And anyway, I remember after about 20 units of blood saying, I'm never writing that drug again. And the patient lived, thank God. But it was at my hand. And I think doctors see this. So we're trained to drug people. We're trained to think that works. A lot of patients think that works. And then people come in with this big list of drugs. We've never seen people sicker than they are now. We've never seen them on more drugs than they are now. And the drug companies are pushing it. I think we're owned by the drug companies. I think the drug companies have taken over this entire profession. We talk about the insurance companies. I mean, I actually think I like the insurance companies more so than I do the drug companies because it's such an incredible marketing ploy. And so we're not trained to treat people through them helping themselves, using herbs, or using the myriad of modalities and alternative ancillary care people that are out there that could help people. So basically I laid there, got educated on other ways of practicing medicine. Again, not through my own initiative really, other than I was just bored and stuck in bed.
So are you finding that patients are coming in today and they're asking, inquiring about what's the other path? I mean, are they beginning to become, number one, more engaged, influencing how they're treated and driving to doctors? I always feel like when I go to my doctor, I'm always afraid to say, well, I heard about this great vitamin or this great herb, and how does that work? And you're afraid to say it because you feel like they're going to go, really, like you think you're the doctor. I mean, how do you begin to have that conversation with your practitioner to say, I really want to look at these, or should I be taking vitamin E, or what are stories? I want to go to somebody who's going to say, what we're learning right now in studies on vitamin E, vitamin C, or any of these things. Risky, not risky. But I want to know because they're easy to get. Should we be doing it? Those kinds of things. But you also don't want to bring things into your basis alternatively that may be doing damage to you as well.
Right. Well, there's several questions there. So I think, first of all, if you have a doctor that you can't go and talk to one-on-one and collaborate in a meaningful way, get a different doctor. This idea that I'm the doctor and you're going to do what I tell you and this paternalistic role, those days are gone. And any doctor that subscribes to that needs to hang it up. The problem is that even the most well-intended doctor may do the most well-intended search of the literature on something and be led astray. Because a lot of what's being published is biased. And in fact, within the Annals of Internal Medicine, New England Journal of Medicine, these very respected journals in medicine, is a plethora of articles addressing this very fact, that in these journals they state and admit and show you that when research trials are published, there is a bias in favor of showing the good, a bias in favor of not showing the bad of the drug. And, for example, recently, a drug company, very large drug company, came to our office, provided lunch for everybody, which I appreciate, and I'm glad my staff enjoyed it, but espousing the wonderful benefits of a new antidepressant. And I should use this antidepressant now, and will you use it? And, you'll use it, right? And I don't even remember the name of the antidepressant anymore, so there you go. Maybe I should take it. Maybe my memory would be better. But anyway, I asked the question, what was the percentage in your trial here of the placebo working? And so for depression, placebo worked in this trial 32% of the time, which is about right for depression. So almost all of the, if you look, review the literature on antidepressants, whatever the drug is, the placebo worked about 32% of the time, kind of a common number. This drug works 42%, okay? So for $280 a month, we can get a 10% bang on depression. And we're not taking into consideration the side effects and risks. And then people don't necessarily stay on the drug as long as they should. So what are we really buying?
Right, and what's the outcome going to be? What do you really get at the end of all this?
And then one of the risks is death, because you could commit suicide, because you can from any of these drugs. So here you're depressed, or you're giving a depressed patient this drug, and you're exposing them to the potential of actually doing themselves in with something that's expensive and a 10% better than placebo effect.
So your company, your practice is called Nova Medical Group.
Yes.
And tell me about all of the services that a patient can get by coming, because I think it's really unique how you have brought all of these components into your practice.
Right. So back to how do we help people? So this very basic question. I'm a doctor. How do I help someone? And I felt like I wasn't helping people with doing all these things. And I cared to hire other people who care about patients. So I think that was the big thing. So I surrounded myself with other doctors who care about people. We're not all perfect. We don't do everything the same way. The question again is?
Well, what's in your practice? Because you've combined a number of services inside your medical practice. So I can come to you for internal medicine. I can come to you for probably my annual exam, my gynecological exam, I imagine. Do you cover that range? I mean, it looks like you've added spa services, you've added other components so that there's like one place where you can come in and get these resources.
Yes, so back to the ABCs. If you go to the doctor has to be equipped to examine you from top to bottom. We all learn this in medical school. So this idea that we're going to carve out body parts and breasts and pelvises only get examined by one group of people, it's just ridiculous. So we all learn this, that no one goes through medical school and doesn't learn to examine the entire body. And so women should not and men should not feel they have to run all over the place to get examined. So as a primary care doctor, be it internal medicine or family practice, there isn't one that graduates that doesn't know how to do a breast exam, a pap, and a pelvic, or examine a man's testicles. I mean, this is crazy that this is, even happening. So, number one, I make sure that everyone that comes in for a physical gets one. I recently went to my OBGYN, no stethoscope was used, no lab work was obtained, a breast exam, a pelvic was done, and I was told I was well. And I was thinking, really? This is ridiculous. And this is what goes on. And women, around this table have had the same experience, I'm sure. That's not an exam. That's not well woman anything. What if you had thyroid cancer? What if you had a heart murmur? None of this is going to get picked up under these ways of treating people. So number one, back to basics, back to Newfoundland. You examine the patient. You get a proper history. You use your brain, and you come up with a reasonable assessment of what's going on. If we could just do that, we would solve so much of what's wrong in healthcare today. So that's the ABCs. Okay, once you've done that, are we going to put everyone that walks in the door on, I call it vitamin Z, Zocor or Zoloft? These are the two big drugs, right?
Like vitamin Z, Zocor or Zoloft, okay.
So are we going to just have a knee-jerk reflex and just, what drug can I write for you? What did you say was wrong? You're depressed? Let me think of which drug. Rather than saying, well, maybe I could help you see the meaning to your life. Because the pill isn't going to tell you the meaning to your life. Maybe you're depressed because you've lost direction in your life. Maybe your visit to the doctor needs to be that, helping put you on track. Maybe the best referral I could make is to a spiritual leader. Or maybe you're so stressed out and you've been through such a terrible trauma, maybe some touch therapy or massage or meditation or a combination thereof. So we can't do our job anymore if we're just going to do this knee-jerk and do, unfortunately, what we're trained to do, which is write all these drugs and perform procedures. Now, there's times when we have to do it. So God bless America. You need the most invasive, high-tech procedure done. You can get it here. And that's great, and I think we need to maintain that and respect what that is. But the problem is when you use this acute care medical model to treat chronic conditions. And chronic conditions, which is what's gobbling up our healthcare dollar today, are a result of how we live. It's how we eat, how we think, how we don't exercise, the fast foods, the toxicities, the pesticides, the food dyes, the flavoring industry. Just Google flavoring industry, and it'll horrify you. Google what the story is on the McDonald's French fry. You would never eat another one in your life. And the only reason you'll eat one now is it's got dye and flavorings in it. You would never touch that mush otherwise. And then where does it come from? It's a long ways from a potato.